welcome. My name is Garnet Gilmore, and I am the Director of Marketing and Sales at Warwick Forest. We are the premier sponsor for the Lifelong Learning Society. I would like to introduce your speaker for today, Dr. Inal. Dr. Inal earned his medical degree from University in Turkey. He completed an internal medicine residency and hematology medical oncology fellowship at Albert Einstein College of Medicine in the Bronx. Dr. Inal is board certified by the American Board of Internal Medicine in internal medicine, hematology, and medical oncology. Inspired to care for cancer patients after several of his residents suffered with the disease, Dr. Inal understands how difficult the process can be for patients and their families. He recognizes that each individual is unique, which is why he believes in tailoring and extensively discussing treatment options with his patients. Patient satisfaction is Dr. Inal's primary goal. Originally from Turkey, Dr. Inal moved to the United States in 2008. He enjoys restaurants, historical sites, fishing, and beaches found around Hampton Roads. Dr. Inal and his wife, who is a nephrologist, have 4 sons. Welcome, Dr. Inal.
Hello, everyone. Thank you very much for this nice introduction. So today, I would like to talk to you about colorectal cancer. By the way, I just wanted to check to see if my voice, you're able to hear it well. Is there any issue? Please raise your hand and let me know if you can't hear me well, so I can raise my voice. So today, again, we're going to be talking about colorectal cancer, which is preventable, beatable, and treatable. And I'll explain in the further slides. So these are the topics we're going to be covering today. We will talk about how common the colorectal cancer is, and what the colorectal cancer is, and what are the causes and risk factors. And we will also cover the screening about colorectal cancer, the tests that we use to diagnose it at earlier phase. And I will also try to briefly talk about what you can do for prevention of having colon cancer, colorectal cancer in the lifetime. So colorectal cancer is the third most common type of cancer in both men and women in the United States, excluding the skin cancers. The most common cancer types in men is lung and prostate, and in women it's lung and breast cancer. Colorectal cancer is the second leading cause of cancer-related death in the United States for men and women combined. And we estimate that about more than half of the colorectal cancer is actually preventable by regular screening tests. And we will be talking about, also we will talk about the options for screening colorectal cancer. So let's talk about some anatomy first. So colorectal cancer, again, it's a term that we use that combines the cancer of large intestine mainly. We use it, we are referring to the cancer that develops in the colon or the rectum. These cancers are sometimes referred to as separately as colon cancer or rectal cancer, but colon and rectal cancers have very common features that we treat very that sort of we treat quite similarly. And so after food is chewed, it travels through esophagus. It reaches the stomach, and then reaches the stomach where it's partially broken down, and then it is delivered into the small intestine. The small intestine is longest pipe in the GI system. It's about 20 feet long. And it basically continues to break down food and absorbs most of the nutrients. So majority of the absorption of the vitamins and nutrients happens in the small intestine. Small intestine then joins the large intestine at the right lower part of the abdomen. It starts at the cecum. That's the beginning portion of the large intestine, and the right lower abdomen. The colon, which is also called large intestine or large bowel, it's about 5 feet long. It absorbs water and salt from the food, and it serves as a storage place for waste matter. So after the waste material, it basically goes up, which we call ascending colon, and then it becomes transverse colon here, and descending colon, sigmoid, and the rectum. So the rectum is really the last 6 inches of the digestive system. And then from there it leaves the body through the anus. So this is just a brief anatomy of the GI system. In the next slide, we're going to talk about how what the colorectal cancer is. So a cancer that happens inside the colon, of course, as the name indicates, cancer is the growth of abnormal cells, and that can invade and damage the normal tissue. So in most people, this process takes many years. It happens very slowly. We're talking about colorectal cancer. It happens very slowly over several years. And before it becomes cancerous, it starts as a polyp, which is non-cancerous. The polyp happens on the inner lining of the colon and rectum. And I'll show you a picture of the polyp in one of the next slides. And so some polyps can transform into a cancerous, invasive cancer, but not all of them do. And we do use the CRC as a brief abbreviation of the colorectal cancer. So you may see, especially in the literature, if you see CRC, it refers to colorectal cancer. So in terms of the causes, I would say that the majority of the causes, the majority of the time, the colorectal cancer is caused by acquired gene mutations. These are changes that happens in the genetic material of large intestine cells. So it is something that we acquire during the lifetime, and these mutations are not present in all of the body cells, but it's only the cells that becomes cancerous over the years. But there are some other inherited gene mutations that can lead to colon cancer as well, but it makes a small fraction of colorectal cancers. But inherited mutations affect all the cell lines in the body. And so I just wanted to say that acquired mutations are a lot more common, and these are the most common causes for colorectal cancer. And we're going to talk about why these mutations are happening in the next slides. But in an individual, though, most of the time when someone comes to us, we really cannot identify in an individual person what triggered the colon cancer, what caused, how it started to begin with. So it's hard to know for each individual, unique person what triggered the cancer. So let's talk about the risk factors. So risk factor is anything that affects your chances of getting a disease such as cancer, but different risk factors, different cancers have different risk factors. So, for example, exposing skin to strong sunlight is a risk factor for skin cancer or melanoma. But tobacco is a risk factor for lung or bladder or esophageal and many other kinds of cancers. So each cancer has different risk factors that can be classified. But the risk factors don't tell us everything, meaning that having a risk factor or having a multiple risk factors does not mean that you will get the cancer in the future. It just increases that chance, but it doesn't mean that you will definitely get it. Or some people who get the disease may not have any risk factor that's identifiable. Or even if a person has a colorectal cancer and has a risk factor, many times it's very hard to know how much that risk factor has contributed to development of cancer. So, but there are some well-known risk factors that have been identified. So let's talk about those. So age is a well-known risk factor that the studies show increasing incidence of cancer in younger people, but the chances of having a colorectal cancer goes a lot higher after age 50. So that's why we start screening, usually around age 45 to 50. Now it's actually age 45. That's when it's recommended to start screening, because after that period of time, that again the risk of having colorectal cancer is significantly higher. Diet, eating foods high in fiber, such as fruits, vegetables, and whole grains, can lower the risk, as opposed to eating diet that is high in red meats or processed meats raises the risk of colorectal cancer. Physical activity, or increasing activity, may help reducing the risk of colorectal cancer. Obesity is another risk factor that has been shown to raise the risk of colorectal cancer in both men and women, but the link seems to be more stronger. Seems to be stronger in men. Not only does it raise the risk of getting colorectal cancer, obesity raises the risk of dying from cancer as well. Smoking tobacco releases some cancer-causing substances which can then be swallowed in, and it can cause digestive system cancers too, including colorectal cancer, esophageal cancer, and such. Alcohol has been also associated with increased risk of colorectal cancer. Diabetes, type 2 diabetes, adult onset. Diabetes and colorectal cancer share some same risk factors, such as excess weight, but even after taking these into account, people with type 2 diabetes still have an increased risk of colorectal cancer. So there are some other underlying medical conditions that are associated with much higher risk of developing colorectal cancer, including inflammatory bowel diseases such as ulcerative colitis or Crohn's disease, or people who had radiation treatment to abdominal or pelvic area to treat previous cancer. These people may need colonoscopy is to start at an earlier age, and may need to be screened more often than normal. And irritable bowel syndrome is not a risk factor for colorectal cancer. So the polyps, of course, especially adenomatous polyps, and or people who had family members with inherited syndromes such as Lynch syndrome or familial adenomatous polyposis. These are inherited conditions that if you have close family members with one of these conditions, then of course that increases your risk of having cancer too. Or people who had colorectal cancer in the past, especially at a younger age, they need more intense screening and maybe more often than every 10 years. That's recommended for people with average risk of colorectal cancer. So you need to talk to your doctor about whether you had a polyp or your family members had any inherited condition, so that can help the doctor to decide if you carry one of the major risk factor or not. So this is a picture of a polyp. So polyp is a growth of tissue in the inner lining of an organ. And there are two types of polyps. One is called hyperplastic, and the second one is called adenomatous polyps. And hyperplastic polyps carries very small risk of being an invasive cancer, as opposed to adenomatous. Those are the ones that are higher risk for transforming into cancer in the future. So, but again, this process, it takes years to happen, typically about 10-15 years in many patients. So it's a very slow process. And that makes it very important to screen, because we will have an opportunity to remove the polyp before it becomes cancerous. So cancer of the colorectal cancer can develop from normal colon, it become adenomatous polyp, and then it becomes invasive cancer. And many times 10 to 15 years, and that long time provides a unique opportunity for cancer prevention through polyp detection and removal. Again, many cancer, let's talk about how we can prevent. So we think that the regular screening test could prevent colorectal cancer in more than half of the cases. And screening is testing to find a disease in people when they have no symptoms. So the screening is important because we can find or remove polyps before it becomes cancer, or if someone already has a cancer, it can be diagnosed at earlier stage, and the treatments are much more effective and provides a lot better clinical outcome when it's detected at earlier stage. There are two types of screening methods. One is called visual. So two broad categories: visual exams or stool-based tests. The visual exams can find both polyps and colorectal cancer. Stool-based tests can only detect or mainly detect the cancer. It's very unlikely that they will detect a polyp. And visual exams are preferred, so I'm going to be talking more about those in the next slide. So these are visual exams, flexible sigmoidoscopy. So again, these tests can detect polyp and cancer. Flexible sigmoidoscopy, colonoscopy, and CT colonography. It's also called virtual colonoscopy. So these tests look inside the colon to find abnormal areas, and they are done with a lighted tube that the GI gastroenterologist put it through the rectum and with special x-rays. And if the polyp is found, they can be removed. And these are the preferred testing if a person is willing to have them, because the intervention can be done at the same time of the test if needed. So keep in mind, these are the screening tests, but these tests can also be used as a diagnostic test. For instance, if someone comes with a blood in their stool and we don't know why, the usual colonoscopy is what is recommended. So in that case, it's used for diagnostic purpose, not for screening, of course. So just let's talk about how the colonoscopy, colonoscopy, again, it's a test that looks at the entire colon, starting from rectum all the way up to the cecum. So it's performed by gastroenterologists in the hospital outpatient setting, or it can be done in a clinic or in the doctor's office. Usually it takes about 30 minutes to perform, but it may take a little longer if a polyp is found. And it can be removed. And so before colonoscopy begins, doctor gives, usually IV sedation so that the patient will feel comfortable and sleepy during the procedure. The patient may still be awake, but they won't be aware of what's going on and may not remember the procedure afterwards. It requires a prep. The colon and rectum must be empty and clean so the doctor can see the inner lining of colon. So usual laxatives must be taken the day before, and possibly enema on that morning. And usually that's the patients often consider the bowel preparation to be the most unpleasant part of the test, unfortunately. And again, I'll tell you that this is still what we prefer, and I'll explain why. The flexible sigmoidoscopy uses a similar, although shorter, lighter tube. It only examines the lower 1/3 of the colon during the test. So colonoscope has a video camera on the end that is connected to a display monitor so that the doctor can see and closely examine the inside of the colon. And special instruments can be passed through the colonoscope to remove any suspicious looking areas such as polyps, or if there's any suspicious area that needs biopsy, the doctor can do it at the same time. If a small polyp is found, the doctor may remove it, and over the time, some small polyps may become cancer, not all of them. This is why they are usually removed, because you can't know at the time of the procedure. You can't know if this is hyperplastic or adenomatous polyp. It needs the pathologist to examine. So the gastroenterologist cuts the polyp with electrical current, and then it is sent to the lab to be checked by the pathologist under microscope and see if there's any cells that have changed into cancer in the polyp. And again, if a polyp and a suspicious area is found during the sigmoidoscopy, usually the colonoscopy needs to be done at a later date, because the whole colon should be examined if there's any suspicious area in the sigmoid colon or any suspicious looking polyp. So usually later on, the colonoscopy will be performed to examine the rest of the colon. Again, sigmoidoscopy only examines the lower one-third of the large intestine. So CT colonography is also called virtual colonoscopy. It uses a virtual reality technology to produce a three-dimensional visualization of entire colon and rectum. So because it's less invasive than standard colonoscopy and sedation is not needed, it may cause less discomfort and take less time to perform, but it does still require a thorough cleansing of the colon to be able to see all the polyps in, or abnormal, suspicious looking area. So the prep for this test is also required. So special computer programs are used to create both two-dimensional X-ray pictures and then the third-dimensional fly-through view of inside of the colon and rectum. The downside of this, though, it only allows you to see it, but if there is any polyp or something suspicious, then it doesn't allow you to do biopsy or procedure at the same time. So you would still need to go through another procedure like colonoscopy after this test if there's anything abnormal. So it will be another prep will be needed, so it's like duplicate. But again, if some people chooses to do so, it's less invasive and less discomfort. It's still, some patients may choose to do so. So these are the stool-based tests. It includes fecal immunochemical test. It's called FIT test, FIT, or guaiac-based fecal occult blood test, or stool DNA tests. So these are the tests to look for hidden blood or other changes inside the stool that could indicate cancer. They are less invasive and easier to do, but unlikely to find a polyp compared to visual exams. And if one of these tests comes back abnormal, the colonoscopy has to be done for follow-up test for diagnostic evaluation. So according to American Cancer Society, colon cancer screening should start at age 45 and stop at age 75. But so people who are in good health and with life expectancy of more than 10 years should continue screening until age 75, as I said. Between age 75 or from age 76 through 85, the decision to be screened should be based on person's preference, life expectancy, overall health, and prior screening history. But after age 5, people over age 85, it is not recommended to continue colorectal cancer screening. So the stool-based test, like FIT testing or guaiac-based testing, is done once a year. And the multi-targeted stool DNA testing is performed every 3 years. And again, if any of these tests is abnormal, then a colonoscopy should be done as follow-up test for further evaluation. The visual or structural exam colonoscopy is done every 10 years. CT colonography or virtual colonoscopy every 5 years, or flexible sigmoidoscopy every 5 years. Again, these are for people who have standard risk of colon cancer. But if someone has a significant family history or inherited cancer history, then they may need to start colonoscopy at an earlier age, and they may need to have colonoscopy a lot more often than what is mentioned here. Okay, so let's go to the next slide. Adults who are at high risk for colorectal cancer may need to start screening before age 45 and screen more often and get more specific tests. And let me just tell you about who are, when we say high risk. So again, as high risk individuals are those with a strong family history of colorectal cancer or certain types of polyps, a strong family history of colorectal, a personal history of colorectal cancer or certain types of polyps, a personal history of inflammatory bowel disease such as ulcerative colitis or Crohn's disease, a known family history of hereditary colorectal cancer syndrome such as familial adenomatosis polyposis, FAP, or Lynch syndrome. This is also called hereditary non-polyposis colon cancer. So these are inherited causes for colon cancer, but again, it makes a small fraction of colorectal cancer in general population. And but these are considered higher risk that they need to be screened at a younger age and screened more often. So what can we do to prevent the colon cancer and to beat it? So let's talk about what we can do in terms of lifestyle changes. So again, get to and stay at a healthy weight throughout life. As we just discussed, the obesity is one of the risk factors. So be as lean as possible throughout the life without being underweight. And improving physical activity and being active also may lower the risk of colorectal cancer. Avoid excess weight gain and be active. Engage in regular physical activity and limit consumption of high-calorie foods and beverages. What is recommended, at least 150 minutes of moderate or 75 minutes of vigorous intensity activity per week, or an equivalent combination, preferably spread throughout the week. And when I said moderate intensity activity, it's those activities are those that require effort equivalent to that of a brisk walk, or vigorous intensity activities are those activities that requires a large muscle, engagement of large muscle groups and causes noticeable increase in heart rate, breathing depth and frequency, and sweating. And avoiding, of course, sedentary lifestyle, such as sitting and laying down and watching television for prolonged period of time. So these are important. Even being more physically active than usual, no matter what one's level of activity is at this time being, can have many health benefits. So eating right foods, again, we talked about increasing vegetables and fruits in the diet, at least 2.5 cups a day, and then choosing foods and beverages in amount, like avoiding high calorie foods and beverages so that you get to and stay at a healthy weight, and choosing whole grains and limiting red meats or processed meats. These are things that helps you or lowers your risk of having colorectal cancer. And also limiting alcohol, no more than 2 drinks a day for men and no more than 1 drink a day for women. The recommended limit of alcohol is lower for women because of their smaller body size and slower metabolism. And in the United States, a standard drink is equal to 12 ounces of beer, 8 ounces of liquor, 5 ounces of wine, or 1.5 ounces or a shot of 80 proof distilled spirits or liquor. So limiting alcohol helps. Again, if you are age 45 or older and at average risk, getting tested for colorectal cancer, whatever method you choose is important. So really, that's the key point here. And I know that some people, it's not nice to, or having a colonoscopy, it's not pleasant, but I mean, I just wanted to point out that there are some other alternatives that at least you can consider. But and you need to talk with the gastroenterologist in your primary care about what is the best screening method for you that you would prefer as a person. But again, any abnormal stool-based testing that if you choose to do so, then you just need to understand that if the test comes abnormal, then you will still need to have a subsequent visual exam for further evaluation. And it's important that your doctor knows about your medical and your family history to find out if you're at high risk or standard risk. And then that helps to decide if you need to start testing it earlier or should have more frequent testing. So that's usually after discussion with the physician. That's how physician will guide you what to do. Screening tests are the best way to prevent colorectal cancers and to find it at earlier stage. And the real outcome is much different, a lot more, significantly different when the cancer is diagnosed at earlier stage because it's potentially curable, as opposed to finding out the cancer when it's more advanced stage, that someone will need to have additional chemotherapy, or sometimes if it's an advanced stage, unfortunately, it's not even curable anymore. So the screening is very, very important. And early colorectal cancer usually have no symptoms, so please don't, sometimes you may think that I'm not having a symptom, so why should I have a screening? And that's really the purpose of screening, that to diagnose it before the symptoms occur, because many times, unfortunately, someone presents with symptoms, the cancer is either already progressed or advanced stage, and it will be harder and more difficult process to treat such cancer. All right, so let me, I know that there were some few questions, so let me go through those questions to try to answer them. But this was the end of my presentation. So this was the American Cancer Society presentation that they basically allow the professionals to use for the public education presentation. So I felt like it's a good resource for us to go through, to go over together. And so let me look at the questions and try to answer them. Sorry. I know that there are 8 messages here. I couldn't open the message. Sorry, I'm not. I wanted to see the questions.
See the bubble there? Yeah, open that. Or
yeah, I know that. Maybe here or.
Yeah, open that. Yeah.
Like this one here.
No, that's not showing it.
Okay.
Let me see. I can actually read them.
Oh, here it is. I found it. Yeah. All right. Yeah, I found it.
Okay.
All right. So let me just. Okay. So I will go back. Okay. So the question, one of the question, I'm just gonna read it from. It's a repeat types of stool-based tests. So the stool-based tests are fecal immunochemical tests. It's also called FIT testing. There's another test called guaiac-based fecal occult blood test, and the third one is called stool DNA test. So there are 3 different kinds. Okay, so the prep. What is it? What prep is required? Another question. What prep is required for flexible sigmoidoscopy? So it does require cleansing, just like colonoscopy too. You would need to speak with gastroenterologist, but in order to see the sigmoidoscopy, just like colonoscopy procedure, you would need to have laxatives before the procedure. Another question. Virtual colonoscopies available, why not just do those? I think that the advantage of direct visual exams or colonoscopy or sigmoidoscopy is that it would allow, again, the physician to remove the polyps at the same session of the procedure, and also if there's any suspicious looking area, the biopsy could be taken at the same time. So that's why I think, it's still an option. I'm not excluding. Some people may still choose to do so, but that's the advantage that I wanted to mention. And okay, so one question: Can you describe the difference in the stages of cancer. So let me talk to you about the stages. Typically, stage 1 is cancer that the cancer is only limited to what we call mucosa, which is the inner lining of the colon. Stage 2 cancers are those typically that is larger and it veins. So the colon is made of different layers. So there's mucosa, submucosa, and then there's outside muscle layer. And if the cancer invades to that muscularis propria, which is one of the muscle layer of that colon as a tube, if you imagine, starting from the inner line to the outside, that becomes stage 2. So basically, that the invasion, more depth invasion of that tumor makes it stage 2. Stage 3 is typically when the cancer is in the lymph nodes. So there are lymph nodes in the abdomen around the adjacent to colon, that if we see that those usually it's usually visible at either on the scans or at the time of surgery when someone goes for colorectal surgery, typically the surgeon will remove at least 12 lymph nodes. That's at least the minimum amount of lymph node that needs to be removed, and that's how we understand if the lymph nodes are involved with the cancer or not. During the colonoscopy, the doctor will not take any lymph node biopsy, so it's not inside of the colon, it's outside, it's adjacent. So it's typically, again, it's either we see disease on the scans or at the time of surgery. That's how we know the lymph nodes, whether the lymph nodes are involved or not. And then if the stage 3, again, usually lymph nodes are involved, and then we would have to offer what we call adjuvant chemotherapy, like 6 months of chemotherapy at that time. Stage 4 is when the cancer is in the distant organs such as liver or lungs or bone. So those cancers, unfortunately, are not curable. It is treatable. The median life expectancy is now near about 3 years with some chemotherapies, and now immunotherapy started to have some role as well, but mainly chemotherapy is what we have available. So unfortunately it's not curable though. So stage 1, 2 usually treated with surgery. Some people with higher stage 2 may need chemotherapy, but typically stage 1 will not require any chemotherapy afterwards. And many patients with stage 2 will not require chemotherapy as well, that it's just treated with surgery alone. Stage 3 patients typically would benefit from the chemotherapy to try to reduce the risk of having stage 4 cancer in the future. And then at stage 4, again, typically there's not even a role of surgery, unfortunately, in those people unless they have obstructive symptom or bleeding symptom from the primary tumor. We don't do surgery on those patients, for those patients, because unfortunately, even if you've removed the primary tumor, there are cancer cells outside of that field that the surgery will not be any benefit to the patient. So we don't offer for that reason. And we offer them, unfortunately, palliative chemotherapy, which can extend the life expectancy on average about 3 years. But what are the common causes of colorectal cancer in people younger than 40 years old? So I would say, if someone has a colorectal cancer at a very young age, the major risk factors are, ulcerative colitis or Crohn's disease, like inflammatory bowel diseases. So that's one thing. The other part, really, the main risk category will be inherited patients with familial adenomatous polyposis or in Lynch syndrome. These are inherited causes for colorectal cancer. Again, those are the major risk factors. What are common? Okay, so at what age should begin screening if both parents have been affected by colon disease? So it depends on their age. It depends on. Usually how. I would assume the colon disease is referring to colon cancer, I guess. If that's the case, usually it starts about 10 years or earlier than the affected family member. That needs to be discussed. Of course, the family history needs to be taken by the gastroenterologist, and usually it will be earlier than the affected parent's age. But I can't really tell any specific age without knowing, of course, a full history of each individual patient. So it's individualized based on the family history, basically. How often do you see stage 3 or 4? I mean, we see the reason we see more often is we are kind of, I think we're in a different position because we are I mean, I'm oncologist, so I do treat these patients more often than people with stage 1 and 2. So we see I mean, it's quite common. It's the second most leading cause of the death in the United States for cancer-related deaths in the United States. So it's very common, unfortunately. And but I would say that most of those patients that we diagnose, unfortunately, those patients who did not go through the screening process at a younger age. That's why I truly believe that if those patients have had their, I mean, that I think many times it was preventable. Does it seem to be higher in Hampton Roads? To be honest, I don't know the answer. I think I need to look into the data and local data and see if in this area the colorectal cancer is higher or not. I know that there are certain type of cancer like mesothelioma was seen a lot more often decades ago because of the shipyard, but as far as I know about, I'm not aware, at least, that the colorectal cancer in the Hampton Roads is higher compared to the nationwide. I just need to look at the data. I'm sorry, I don't know that information at this time.
So you can see if there's any more questions. If not, that's it.
All right. Okay. Thank you. At what stage do people experience symptoms? What I have seen is usually, unfortunately, when they experience symptoms, it will be usually either stage 3 or 4. Sometimes some patients come to us with iron deficiency anemia. Just that's the only symptom they have, that they feel fatigued, not because of the cancer, just because of being anemic due to bleeding from the tumor, and then over the time it causes the iron to be depleted from their system, so they come to us with iron deficiency anemia, and they're the lucky ones, because really when we see someone with iron deficiency anemia, and if they haven't had colonoscopy, I don't treat just the iron deficiency only. I always refer them to GI doctor to get it tested, because we may still be able to detect, catch the cancer, detect cancer at earlier stage, either stage 1 or 2, if they present with iron deficiency anemia. But the many times that what I've seen is either stage 3 or 4, like when they have either pain related to the cancer in the liver. Typically, colorectal cancer, unfortunately, commonly spreads to the liver, and sometimes bone, lungs. These are the organs that it may spread. And some people may just present with pain, unfortunately, that when they come in, we see that the cancer already spread it to the liver, that unfortunately there's no curative option at that point. But let me take it back, actually. Let me just say this. Even there are some patients, though, who would come to us with stage 4 cancer, but the cancer is just spread to a limited extent into liver. Like you would see, there are only 1 or 2 tumor forming in the liver that are potentially resectable with surgery. And there has been reports that actually there's a good data showing that if someone has a resectable metastases at the time of their presentation, we do offer them aggressive care with surgically removing the tumor, the primary colon tumor, as well as removing that metastatic site in the liver, because such an aggressive approach could still result in long-term survival, like 5 years or more, if all the disease at the time of presentation is surgically removable. So even if it's stage 4, and even if it's not curable, we know that taking the primary and the metastatic sites, if surgically feasible, would allow the patients to live longer. So I think it's still not a cure. I wouldn't call it cure, but definitely it results in a lot better long-term outcome compared to not doing surgery in those cases. But we do. That's why if anyone comes to us with stage 4 disease, we always evaluate them to see if it's surgically resectable or not. So with the COVID present in society, it is better to hold off on getting a colonoscopy if it is time. I had a test scheduled for the summer and canceled it because of concerns about COVID. I would say this, I mean, depending on each individual cases, I would not, I mean, right now hospitals are taking extra precautions too. We are aware of the concerns in the public about the COVID and not, coming to the hospital and doctor's office. But also I just wanted to remind you that the hospitals also are taking extra precautions to make sure that everyone can receive their care as safe as possible. So, and it's just hard to know how long this is going to be continued. I mean, I hope that the vaccine will be available, and I hope that the COVID, will be under control or over next year or so. But delaying the care, at this time being, in my opinion, it's very unpredictable that someone is, if you already have, I mean, again, for each individual is different based on the age and based on the symptoms or based on their risk category, but I would not recommend delaying it just because of the COVID, because as I said, we are taking it very seriously as well. And we do, just to give you an example, that during this COVID season, COVID pandemia, we were able to continue our cancer care without interruption, and we really didn't have, and I just want to knock it on the table, that we didn't have any significant number of cases. I mean, I don't have any patients that I can think of who died of COVID because they were getting cancer care at the same time. I mean, of course, we cannot generalize and say everyone will be safe, but I can tell you that as long as the extra measures and precautions are taken, I think we should still continue the medical care as much as possible, because I mean, delaying the care, you never know who gets the colon cancer, and saying that, oh, it's okay to delay it a year or so, and then somebody gets a cancer or diagnosed with cancer at a more advanced stage, it's just going to be, very, very bad, because the outcomes are so different. Catching cancer at stage 1, 2 versus stage 3, 4, it's a lot different. How do you clean the equipment? Is it foolproof? I really don't know. Let me tell you, I'm a medical oncologist, so I am, I'm treating cancer patients, but I'm not the one who does the procedure. So it's usually performed by gastroenterologist. So I don't know how it's cleaned, but I know that the hospital, has, takes the risk, basically takes care of the equipment and make sure that it's cleaned up. I just don't know how the actual process is, though. Thank you very much, everyone, for joining, and I hope that I was able to provide you some useful information. It was, and thank you very much for giving me this opportunity and letting me engage with the public, with people. And I just wanted to tell you that if you have any questions or concerns, we are available, and we'll be happy to address your concerns or questions if you need any help from us. I guess if there's no further question, I will just end the lecture here. I hope happy Thanksgiving to everyone, and I hope you will enjoy your weekend.